Okay, perfect. So last time we were finishing the supraesternal views. And one thing that, we can see in one of the modified parasternal short axis or high short axis view, which is close to the suprasternal actually in many of the babies, is the branching pattern of the pulmonary arteries. So you can see here that, we can see the two pulmonary arteries. We have the RPA and LPA. So we can see that sometimes they have a tendency. So it looks like, oh, Sylvia, I think you have your microphone on. So we can see that it's like, it looks like an inverted Y. Sometimes they call it the pants, sometimes they call it a mustache because it looks like a mustache. And then in this area, it's a good place to make sure that there's no acceleration. And very typical, we see in babies that there is a bit of acceleration because they have a tendency to have a bit of a acute angle of division, which tends to become less angulated as the patient will grow into the pediatric life. So it's very common to have, some degree of acceleration. We often call it peripheral pulmonary stenosis, like the murmur of peripheral pulmonary stenosis. And as you can see, I've outlined here how the American Society of Echo recommends the measurement of the main pulmonary artery, right pulmonary artery, and left pulmonary artery, basically at their branching of the MPA. And you can see that this is at the peak of systole. Why do I say peak of systole? You can see that it's when the valve is open. So the valve opens during systole. So you want to measure it at its largest diameter, which is when you have flow inside the artery. And there are Z4 to make sure that you don't have dilatation. And sometimes you will see dilatation in babies that have high pulmonary vascular resistance, and they may have like signs of like what we call like swirling. It looks like a toilet bowl. Well, because you get this dilation and because you have high peripheral or pulmonary resistance, you end up getting like kind of blood flow coming back during portion of the cardiac cycle. And it's also a good view to see if there's like a massive clot, although this is something very rare in newborns. It's something that can happen if they had like an indwelling catheter and that the clot kind of embolize. So we can do a pulse wave Doppler in the right or in the left pulmonary artery. And then, typically if you're below 2 meters per second, it tends to be within normal limit. So that's pretty much, the for the RPA and the LPA. So now we're going to go over a bit of the assessment of the ductus arteriosus, which is a very large subject and on its own could be an entire presentation, but I'll stick to what we look for in the echo views related to the PDA. So we'll start with the left or right PDA. So typically what you're trying to see is this trifurcation where you have the ductus arteriosus, the left pulmonary artery and the right pulmonary artery. And sometimes in different views, you may see like the PDA connecting to the descending aorta. And here you can see the isthmus, and it's, part of the descending aorta that is preductal. And that's why in color, you can actually see that your LPA is here and your ductus is here. So we can still see the whole course of the ductus. So we would be able to measure, for example, its narrowest diameter, which is typically at the pulmonary end. And ductus arteriosus may have many different shapes. They can be, serpentine. They can be like a silo or longitudinal or cylindric. They can be very, they can be, more posterior. So it really depends the ductus, but typically this is the conformation that we see in premature babies, for example. And what we want, and in this case, we almost can appreciate just by color that this duct is like pulsatile. It looks like an artery that pulsates, like you can see the acceleration in systole, and you can see that, the red velocities become less pronounced in diastole, just by the color scale, which here is very high. It tells you that these are very high velocities that are appearing. And so whatever is red means that it's going towards the probe. So it's coming from the descending artery and it's going towards the pulmonary artery, which tells you that this duct is left to right. So it's coming from the descending aorta to the pulmonary artery. So the one thing about the duct is that it's a structure that connects the pulmonary vasculature to the aorta. And so in that sense, it will be subjecting the two systems to shifts in pressure and volume during the entire cardiac cycle. So during systole and diastole. So for example, when it's left to right, it will transmit blood as a volume, but also will connect the two systems. And so in this context, the pressure should equalize between the two systems, right? So when you have a large duct, when you have something that will equalize quickly the pressure between the two systems, well, by definition, your pulmonary system will be systemic, will have systemic pressures because you're going to equalize the pressure on both sides. So it won't tell you what's happening distally to the PVR. We probably know that when you're subjecting the lungs to excessive flow, the PVR will slightly increase, but as a reaction to the increased flow. So it's normal to have higher PVRs to dampen the flow, but it's not like it's a reactive increase. It's not like a fixed increase or of normal pulmonary vascular disease where they have much more smooth muscle in the wall of these vessels. It's really reactional to the fact that there's increased pressure and flow transmission. So typically, we measure the ductus arteriosus and at the narrowest measurement because it's like a funnel. So you want to see what's the narrowest measurement. And then typically you want to measure it in the 2D view where you see the two borders of the wall. And because babies are of different weight and of different size, we will have a tendency to try to normalize it to a ratio that may be able to help us express how much of a size it's significant or not, if we're looking only at a size criteria. So it will often be expressed to the left pulmonary artery or to the weight of the patient at the time of the echo, and it's measured at its narrowest diameter. So here you can see that, your PD is around 0.26, so 2.6 millimeter, and the left pulmonary artery is 2.4, so the ratio is almost 1-to-1. So your PD is almost the size of your left pulmonary artery. So this is like, the same recommendation, but coming from the American Society of Echo, where they mentioned that, you take the diameter perpendicular to the interior wall of the pulmonary artery end. So, this is the interior wall of the pulmonary artery, like here. And so you can get your diameter at its junction when it's connecting to the main pulmonary artery. So then you want to obtain the velocities through this flow in order to describe if there is rapid or non-rapid equalization of pressure between the two ends. So we'll typically take a pulse wave Doppler. So here you see we're at pulse wave Doppler, it says here, or pulse wave Doppler, it says here. And you can see that the profile has a tendency, so you get your QRS and systole, and then eventually a very rapid equalization, like the velocities are almost close to zero. So it tells you that in diastole, there's very rapid kind of equalization of velocities or pressure on both sides, which means that this duct is probably, equalizing pressure on the aorta and the pulmonary end. And this is similar. You can see that this is very pulsatile. And what we're trying to see is that, as the ductus is supposed to get narrower and narrower, well, it's going to become what we call more restrictive, which is a very subjective term, because what restrictive means is that it restricts the amount of volume and the amount of pressure that is transmitted to the lungs, right? That's the idea. Or if it's in the other direction, that it restricts the pressure or the volume transmitted to the system, to the aorta, if it was a right to left shunt. So typically the restriction will occur as this, first of all, this structure becomes narrower because it becomes like a funnel. So think of you going into the garden and, putting water on your plants, and you're taking a hose. if the hose is becoming narrower and narrower, eventually the pressure will build up on the end that receives the water, and it will like kind of spurt into the environment. So it's going to do pss, 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 pss. That's the idea of being restrictive. And that's why the speed at which this jet is coming out is much quicker. It's a high velocity speed because the pressure differences between the two environments is a big pressure difference, right? The pressure builds up into your hose because you're blocking the flow of water, and it's trying to get into the environment, which has, atmospheric pressure. So it's a huge pressure gradient. And that's why we say that it's restrictive. But you can imagine as you're trying to put your thumb over the opening of this hose, how much you can control the amount of restrictiveness you're giving to this opening. And so that's why it's very subjective when we say, oh, it's restrictive. It's mostly an appreciation that the velocities are relatively high and that they're relatively high throughout the cardiac cycle. And in the sense, you don't get this drop to zero, because this drop to zero tells me that each time there's a gush, it's like blue, blue, blue. There's no blockage of flow. The velocity of it is very small. So that's why they get these pulsatile kind of flow. So imagine like a heart that's pumping and you have an aorta and it's just pumping into the void, right? You get this pulsatile kind of spurt of blood. It's the same, but you're connected to the pulmonary artery instead of to be connected to the environment. So we can use these flow patterns and get at the peak of systole and the peak of diastole. And if you know the blood pressure in your system, you can get an estimate of what would be your pressure in your pulmonary artery, in the sense that, let's say you have 45/10 on your system. Well, if you remove this gradient of 23, it gives you 22. And if you remove 1 from the 10, it gives you 9. So it's like 22/9. But this is a very poor approximation of the pressure in the pulmonary artery. Why? Because it uses the Bernoulli equation, which has the assumption that you're calculating this along one narrow point. And we know that the PDA is not one narrow point. It's actually a tunnel. So it doesn't accommodate all the assumptions of the Bernoulli equation, but it gives you a sense that for sure, when you start seeing, that you have these velocities and pressure, the compartment on the pulmonary end has likely lower pressure, and we can presume has likely lower pulmonary vascular resistance relative to the systemic vascular resistances. But when it's wide open, the pressures are going to equalize very quickly. And what you can only assume is that the pressure in the vasculature of the lungs is kind of similar to the pressure in the systemic vasculature. And that's because it's flow driven. It's not because there's underlying high pulmonary vascular disease or high pulmonary vascular resistances. And in these contexts, it's much more difficult to delineate what's the PVR, underlying to the condition. So if you see very low velocity and a very tiny duct, then it's a bit concerning, because if you have a tiny, tiny duct, it shouldn't give you these low velocities. You should have relatively high velocities. You should have this effect of high restrictiveness. So if you see low velocities, you start being concerned, well, is it a signal issue? Is it that I'm not aligned? Is it that I'm not getting a full curve? Or is it that there's actually very high pulmonary vascular resistance, and that's why the velocities are low? Is that clear? Perfect. So, when you start having a left to right shunt, that brings a lot of blood flow into the pulmonary vasculature. You're going to often start finding that in your RPA or LPA, you start having extension of diastolic flow. And that's exactly, what I told you, that because it's a structure that's connecting the aorta to the pulmonary artery, the flow is often throughout the cardiac cycle. So you can start getting acceleration of flow even in diastole when you're not supposed to have much flow in the pulmonary arteries. So that's one of the, element that we look for when we have PDA, is to see some of the end diastolic velocity properties. So just a reminder, I've put here like kind of the normal pressure that we see in an adult. Obviously, the concepts are similar for a term baby, but you would not have 100/60 of blood pressure. You would have something like, 60/20 of blood pressure. But starting the age of 3 months, these are, the values you would see on the right-hand side. So your RA pressure is around 3 of mean. You have about 75% of saturation. This is your venous saturation coming back from the brain and the lower body. And this saturation will obviously start dropping if you have a very severe anemia or high metabolic demand, if you're seizing, if you have metabolic conditions that requires a lot of oxygen consumption, or if you have poor output, it could also drop the saturation because the blood flow is going less through the body, and so the body will tend to extract more oxygen for whatever blood flow it's getting. So this is the central venous saturation, and this is what we call the central venous pressure. And this pressure will start rising if you have, for example, an obstruction at this area, or RV that's having difficulty, like think about the right ventricular failure or diastolic failure. If you have a tamponade, for example, you're going to have an increase in your right atrial pressure because the right atrium is not able to empty into the right ventricle. If you have stenosis here, or let's say you have a massive interatrial shunt and you get a lot of blood flow coming back, you may have increased right atrial pressure, because it's a loading lesion. And that's true often when the kids are at a bigger age, not in the neonatal life. It's rare that we'll see that these babies have high right atrial pressure right from like the first few weeks or months of life, right? It's really an effect of chronicity, and that's why we say that interatrial shunt are often volume lesions. Other reason why you would see a higher right atrial pressure are, of course, if you have high volume coming back from the SVC or IVC. So we spoke a bit about the AV malformation that can bring back a lot of torrential blood flow to the right atrium. You can think of, if you have a clot. So let's say you had a catheter and you have a clot here. Let's say you have a constrictive pericarditis. So that's like more in the context of like patients with cardiomyopathy, or patients who have like, I don't know, radiation exposure or cancer or lymphoma. Patients with Epstein anomaly that have a lot of TR, so they can have increased right atrial pressure, and that's why they get right to left shunt a lot at the atrial area, which brings a lot of deoxygenated blood to oxygenated blood. And of course, depending on the volume shunt that you get here, if it's right to left, it's going to contaminate more or less your preductal saturations. So if you get a lot of volume that's deoxygenated entering your left atrial cavity, well, of course, systemically, you're going to be more desaturated compared to if you get just a few RBC going there. It makes sense. So it's an average effect. So your mean pressure in the right atrium is about 3, but it's more complex than that. It often has, a multi-phase pattern. And eventually, your pressures into your RV is around 25 to 30 of systolic and about 3 to 5 of diastolic, which will fluctuate depending on its filling. So we'll go down when it's empty, and that's why the tricuspid valve opens, and the right atrium pressure at this point is probably closer from 4 to 5 because it has filled during the closure of the tricuspid valve. And so the right atrium will empty into the right ventricle, and eventually the right ventricle will start contracting. There will be pressure buildup, and at some point this pressure will be higher than the diastolic pressure into the pulmonary artery, and that's why the pulmonary valve will open. And eventually, when the pulmonary valve is open, you get equalization of pressure between your pulmonary artery and your RV, and your reach value between 25 and 30. You send blood flow to your lungs. Lungs will empty into the left atrium via the pulmonary veins. And if you do have, if you don't have any constriction of your pulmonary veins, so think about pulmonary venous stenosis at the ostium, or pulmonary venous occlusive disease, which means that you get a diffuse or partially, affected pulmonary venous drainage system where they start constricting, or you have clots in your veins, like, you can think about some of the thromboembolic disease of the lungs, where they can have clots in the arteries, but also in the veins. Well, the pressure here should be the same as the pressure in the vein, right? And ideally, it should be the same as the diastolic pressure, because when the valve opens here, this pressure, and this pressure should be the same. They're all connected. So when we're doing a cath lab, we'll often measure the wedge pressure. Do you know what's the wedge pressure? Have you ever heard of that? Pulmonary wedge? Pacini, would you know what's the pulmonary wedge pressure? You're muted. Or Sylvia? No? So the wedge pressure, can you guys hear me? I just want to validate.
Yeah, we can hear.
Okay.
Yeah.
So the wedge pressure is trying to estimate actually the pulmonary venous pressure and the left atrial pressure and the left ventricular and diastolic pressure. So what does it do is that they put a catheter in a pulmonary artery, they block the pulmonary artery, and they actually measure the pressure distal to that blockage. And if your pressure distal to that blockage is very high, it could be because your pulmonary venous pressure is high. Let's think about pulmonary venous blockage. So ostial stenosis, for example. It could be because your left atrial pressure is high, or it could be because your LV and diastolic pressure is high. So then you need to go and figure out what's the part that's high among all of these. So what's difficult by cath is to access the left side of the heart in tiny babies. Why? Because it means you need to puncture an artery, or that you're able to do so by going through the foraminal valley. But if there's no foraminal valley, or if it's too tiny, sometimes imagine a little hole and they're trying to thread a catheter through that in the 3D structure of this wall, and they're not able to, and the catheter is flickering like this. So they're trying to access, obviously, the left side if possible, but sometimes it's not possible. So if you're able to measure the pressure in the left atrium and you get 6, but your wedge pressure in one of the pulmonary arteries is like 20, well, it tells you that the blockage is somewhere in the pulmonary vein. It's not left atrial pressure that's high. But let's say you get into the left atrium and the pressure there is 20, or it's 25, or it's very high millimeters of mercury. So it tells you it's the left atrial pressure that's high. So then you need to figure out, is it the left atrial pressure that's high because the LV and diastolic pressure is high, or it's because there's something between the LA and the LV? So what could be these things? It could be mitral stenosis, it's blocking the way. It could be severe mitral regurgitation, or there could be a mass into the left atrium that's causing blockage of the inflow of the LV, like myxoma and all these things, which is rare in pediatric or in the newborn population. So if you have high LA, but normal LV and diastolic pressure, you have to think about LA diseases, I just mentioned. So in adult populations, they'll often have like significant mitral regurg, significant mitral stenosis to explain that. But some of our population of patients may also have these kind of situations. So you can think about patients with small left ventricles, parachute mitral valves, abnormal atrioventricular valves on the left side. So, patients with, for example, some of the imbalanced AV canal and things like that. So that could be one of the reasons why they have LA hypertension. And when you have LA hypertension or pulmonary venous hypertension, you can get a phenotype of what we call post-capillary pulmonary hypertension. And then the last thing is that, let's say your LA is high also, you go into the LV and you can see what's the LV pressure. And if the LV pressure is very high, you can suspect in diastole, usually the LV pressure in diastole is very low. It could be because you have LV remodeling, so hypertrophy, cardiomyopathy. You can have significant LV dysfunction. So if you have significant systolic dysfunction, eventually the LV has difficulty emptying, so it's still overfilled whenever it's time to empty. So the LV and diastolic pressure may rise. So you could have LV fibrosis or ischemia. So all these reasons could lead to, high LV and diastolic pressure. Some syndromes like Turner can be associated with high LV and diastolic pressure. So this can be reflected at the LA level and at the pulmonary vein level. And by echo, if your RA pressure is normal, but your LE pressure is very high, and you have a PFO, you can get to see a very, rapid gradient through this PFO. And you could measure this with a CW or a PW, and it's going to give you a sense of the differential of pressure between the atriums. So if you have like a shunt via an ASD that has a very high velocity or that looks very restrictive, which means there's turbulence through it, you can actually measure the velocity through it with a pulse wave Doppler or CW, continuous wave Doppler, and you can get a sense of the relationship between the LA and the RA pressure. And if you have a gradient that is 15 or 10, this is high. It tells you there's something happening into the LA that is increasing the pressure. One of the other reasons why you may have increased LA pressure, which eventually should normalize because this is a structure that will end up dilating to some degree, is that if you have torrential flow coming back. So the same way, if you have a vein of Galen or hepatic hemangioma and you get torrential flow coming back, your RA pressure may start rising a bit. You can go to 5 to 6 to 7 of pressure. And that's why if you're putting umbilical lines on these babies, they have a tendency to easily bleed because the RA pressure is so high from all the shunt. So if you put a baby with a vein of Galen, a UVL, these UVLs are tough. Like you need to like really stitch them very high because they have a tendency to kind of bleed a lot. So you'll see that if you have a patient like that. So same thing, if you have a PDA with a huge left to right shunt, your LA pressure may start rising. And that's why we start seeing the LA becoming more generous in size and dilate. That's why it starts dilate the mitral annulus and the LV because you get a lot of preload to your left side. You can start seeing higher velocities of flow going through your pulmonary veins because the pulmonary vein is a relatively fixed structure. So if you increase the flow through it, the speed will start increasing. And so that's why we measure all these elements when we're assessing a patient with a PDA as a marker of how much pulmonary overcirculation is happening. The other concept I want to remind you is that pressure is a function of resistance and flow. So when you connect these two structures together, obviously, if the resistance here is low and the resistance here is high, by definition, you've connected the two systems, so the pressure will be equal. So how is this pressure gonna rise? It's by increasing mostly the flow. So that's why we say that the PDA is increasing, a lot of flow to the pulmonary vasculature in the left to right, and that's why there's like concern that it may, lead to eventually some pulmonary vascular remodeling. Although we know that in preemies, this has not been like completely proven, and that a lot of premature babies will have a tendency to close on their own when they acquire the mechanism to close the ductus or to restrict the ductus. And I will not go into the controversy about, like acceleration of ductal closure in preemies. But really, we're just going through the assessment. So when the PVR are much lower than the SVR, the RV and the PA pressure may be the same than the aortic and LV pressure if you have a huge PDA, but what's going to happen is that you're going to increase this flow significantly. The other thing is that think about patients who have like severe acute pulmonary hypertension with high pulmonary vascular resistances. If you have a ductus here, what's basically going to happen is that you're going to shunt a lot to the aorta and send a lot of blue blood into your descending aorta, which will basically pop off the pressure. It will equalize the pressure between the two systems, helping the RV, which might be struggling, to decrease, the actual afterload by popping off into the aorta. but it will basically expose the RV to systemic pressure. So some of the things we'll look in a left or right PDA shunt are things like end organ perfusion by ultrasound, so markers of end organ perfusion. So this is an example of the descending aorta. We even see an umbilical arterial line that's kind of floating in it. And we can see two vessels branching from the descending aorta. So we have like the diaphragm here, which is this white line. We have the liver. And then we see here the celiac artery, which will have a tendency to generally provide blood flow perfusion to the small intestine, but the upper portion of it. And then you have the superior mesenteric artery, which will also provide to the rest of the small intestine the blood flow. And so here you can see patterns where, for example, I'm doing a celiac artery pulse wave Doppler, and I can see that there's like almost absent and diastolic flow, versus here I can see that there's continuous systolic and diastolic flow throughout the cardiac cycle in this patient who has no PDA. Similarly, this is a view of the transfontanelle heart ultrasound, where here we're obtaining a view of the ventricle, and you have here the anterior cerebral artery and even the pericallosal artery. And we can also do a pulse wave Doppler, and here you can see that there's actually continuous flow that is forward in systole and diastole, versus in this particular baby where I'm doing the coronal view, so I'm doing the cross-sectional view here, you can see that we have the circle of Willis, and then we have the branching into the middle cerebral artery. And if I'm obtaining the Doppler, typically you get a better signal at the junction of the circle of Willis. And you can see here that there's QRS, positive upstroke in systole. And in this particular patient, you get complete retrograde flow throughout the diastolic phase of the cardiac cycle. And that's a steal effect. So it's a marker that there's a steal from the brain. And in this particular baby, it's secondary to a ductus arteriosus that is shunting left to right inside the pulmonary circulation. Another example here, where you can see the negative velocity, which means the blood flow is going kind of retrograde. And then the retrograde flow, this time it's in the middle cerebral artery, so we can see the circle of Willis, and you can see the branching of the MCA. So that's how we quantify the degree of this effect of shunting. So we can use a marker called the resistive index, which is basically the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. So if you're above 1, it means that you have retrograde flow because the end diastolic velocity becomes negative. And typically we say that in PDAs that are insignificant, values of 0.8, 0.85 and below is typically within normal limits. So this particular patient you can see has an RI of 0.71 versus this patient is above 1 because it has some retrograde flow. So this is an example of how we would trace it. We would get the Vmax, we would get the end diastolic velocity, and we can also get what we call the mean velocity by tracing. So that's the mean or the average velocity throughout the cardiac cycle. And sometimes we can use the mean velocity to calculate something called the pulsatility index, which if you go on the Neocardio lab in the POCUS section and head ultrasound, I'll just share. And I think Pessini is very aware of that because her project is on pulsatility index. So the pulsatility index is really the peak systolic velocity minus the end diastolic velocity, all this divided by the average velocity or the velocity mean. Okay, let me go back. So that's an example of peak systolic velocity and end diastolic velocity. And so we can do the RI by doing 0.71 minus 0.11 divided by 0.71. And we can do the pulsatility index by doing 0.71 minus 0.11 divided by 0.307. So these are just example of the flows the end organ flow assessment. So here showing you the celiac artery and the SMA. This is from the TNE guidelines. And then here they're showing the middle cerebral artery, but they take their view from the approach that is on the side of the head to obtain the images, which we don't do locally at our lab because the images sometimes are more difficult to obtain. And with the fontanelle, it tends to be very clear. But you can use this technique too. So when we talk about small PDA or restrictive PDA, again, restrictive or unrestrictive remains a very subjective assessment. Here you can almost see that, at its narrowing, there's like a flame of blood flow coming into the pulmonary artery. It's left to right, it's very tiny. And then typically it will have this pattern of sawtooth appearance where you don't get the velocities going back to zero or near zero or very low end diastolic velocity. So you lose a bit of this pulsatile flow. And that means that the actual PDA, instead of being a tunnel, is starting to restrict like this and become much more narrow at its pulmonary end. So for example, in a baby like this, you can see that you have the PDA and you can see this pattern that looks like more sawtooth, with really the pressure between the pressure, like what it's outlining is that the velocity are not going back to zero. So there's always, a large pressure difference between the systolic and diastolic end of the pulmonary to aortic ratio. So in this particular baby, you could assume that probably your pulmonary systolic pressure is at least 49 below the systolic blood pressure in the aorta at the time of this image acquisition. So if you have, for example, 70 of systolic blood pressure, probably your systolic pulmonary pressure is around the 20-21, which is like the normal value that you would expect, right? From the previous graph that we shown. So you would expect between 25-30 of systolic, and these values are true for babies that are 3 months old and older and that are born to term. We actually don't really know what are the normal transition for other conditions, but we assume and we do think that based from all of these other observational studies that these babies should reach these values at around the term corrected age when they're born premature. So here, these are other example of, this is an example of a, duct that does not seem to have constricted yet. It's left to right, and it has a bit of that pulsatile behavior. But it does tell you that there's still a bit of a gradient between the aortic and pulmonary end of 19 millimeters of mercury. Versus if you contrast with this one is non-pulsatile. It's almost like a flat line, right? You see that? But meanwhile, the flow or the PDA looks very tiny. And that's a baby basically that has pressure in the pulmonary and pressure in the aortic end that are quite similar. And you can assume because it's tiny that it's likely that the PVR and SVR are similar as well. It's an assumption, which gives you this pattern where the gradient between the two ends is like 1 millimeters of mercury. You can see 6 millimeters of mercury, sorry, 5 to 6. So let's say your systolic blood pressure at that time was like 100. It tells you your systolic pulmonary pressure is lower than the systemic pressure, but only by like 5 or 6. So the actual PA pressure is very high. But even if it's left to right, this is a very low velocity profile. It tells me that in the PA, probably the pressure are getting close to the systemic pressures. Now, that being said, it could be because the systolic blood pressure in the system is very low too. So imagine this baby or this kid had a blood pressure of 20/10 in the aorta. That's very, very low. And so if it's 20/10, it means the PA pressure is actually like 14 of systolic pulmonary pressure, which is completely normal for a pulmonary artery. But because you're so profoundly systemically hypotensive, it gives you that kind of profile. Does that make sense? Because it's always a relationship between the two compartments. So again, this is a reminder. So here you have the trifurcation. In this particular view, you get your PDA here. So you can measure your PDA in relationship to the left and the right pulmonary artery. When you're having more of a suprasternal approach, you can see the arch. And you can actually see the ductus here that's going up and connecting eventually to the pulmonary artery, which comes in a perpendicular manner. And you can actually see its course with the aorta in the background. And this is a particular good view to obtain the pulse wave in the descending postductal aorta. So this is definitely a view that that locally we use a lot to see if there's retrograde flow in the descending aorta. So bidirectional PDA can be a bit more tricky to kind of interpret. But basically, if you have a very large duct, you expect that the pressure will equalize on both sides. But if you have a significant component of right to left shunt, it's probably that the PVR are higher than your SVR. But if your component of right to left shunt is very minimal, it could just be that you get this very, very rapid pressure equalization. So you have then to put everything into context. Do I have retrograde flow in my aorta, for example? Do I have other sign of pulmonary overcirculation? Do I have signs that, what's the relationship between the systemic blood pressure at the time of the echo? Do I have signs that my RV is struggling? Is my PFO right to left? So that provides you more information about the overall picture that you're trying to define. So this is you can see that this duct in particular is a very large duct. And at this point, it's right to left. And then it becomes a bit left to right, and then you're right to left, and then a bit left to right, and then right to left. So this is the pattern that we see in this particular patient. In this particular patient, I know the clinical context. This is a baby that had CDH, who had severe RV dysfunction, who was very blue, who was shunting right to left at the PFO level, and the PDA was becoming restrictive. So we actually induced that. We gave PGE, we opened the PDA, and what happened is that the pressure in the pulmonary compartment became isosystemic. And now you get a larger volume shunt from your RV to your descending aorta. And obviously there's differential saturation, but it allows the RV to recover because it pops off the RV. So this particular patient has very low velocities, very large duct, and there's rapid equalization of pressure because these velocities are very low. They're like below 1 centimeters per second. Compared to this one, this was actually the same patient before we gave the PGE. And you can see that the velocities are much higher. They're above 2 meters per second. So you get a component that there is some degree of restrictiveness. So if you see this patient has a right to left difference of 30 millimeters of mercury. So at the time of this echo, this patient had like a blood pressure of 60 over 35. So if you're 60 over 35 and you add 30 to your systolic blood pressure, that means the systolic pulmonary pressure was like 90, right? So you're in the suprasystemic systolic pulmonary pressure by 30 millimeters of mercury. So definitely in this particular baby, there was some degree of restrictiveness, and that was presumed to be secondary to underlying high afterload or possibly high pulmonary vascular resistances. So this is an example of a bidirectional PDA with a gradient of 3. But the difference here, you can see that the timing you're spending into the right to left portion, like look here, right to left, left to right, right to left. It's almost like 1 to 1 or 1 to 3, I would say, right? Here, like, look, you're spending almost the entire time of your cardiac cycle left to right. So in this particular baby, I would suspect, could there be a component of just rapid pressure equalization? So this PDA, just seeing it here, could be a baby, like a preemie baby, like the first day of life. So we often see that, like the first day of life in a preemie who still has a bit of a higher PVR, the PVR have not dropped yet. and it's a huge duct. So in many of the trials, this patient would have been recruited to give one of the treatment drugs, right? Because large duct, low velocities, majority of it is left to right. And as the baby becomes bigger, like not bigger, but I would say older, and the PVR are dropping, you're going to start losing this right to left component. You're only going to see this pulsatile component. Here by color, we see kind of the bidirectional shunt in this ductus. And we could see this, for example, in the patient with a coarctation or interrupted aortic arch. So you have to be careful to not miss that when you see a bidirectional shunt. Right to left mean that the gradient is favoring a gradient from the pulmonary end to the aortic end, which means that it could be because the PA pressure here is very high compared to the aortic pressure, either because this is abnormally high or this is abnormally low, or a combination of both. And so here you can see that the actual tract of the ductus is very tiny. There's a lot of turbulence, and there's actually a gradient of like 46 millimeters of mercury. So that tells you that, you know, the PA pressure is at least 46 millimeters of mercury above the aortic pressure. That could be seen also in a patient who has like a critical coarctation and the PD is closing, right? Because the aortic pressure becomes so low here that whatever flicker of flow you're able to generate, it's your RV that's able to pump some blood flow into the aorta. But it could also be the picture of a patient who has severe PPHN or acute pulmonary hypertension and the duct is closing. Okay, so right to left, this is how we would measure the gradient. This is another example. This time it's a large duct. I think you can appreciate how it's like almost bigger than the left pulmonary artery and the right pulmonary artery. This is the whole ductus, and clearly it's blue throughout the cardiac cycle. And in this context, of course, the pressure on both ends will likely be very similar because you're equalizing pressure. But this tells me that likely the PVR are much higher than the SVR, right? Because it's following the gradient of resistance. So there's pressure equalization, but PVR or afterload is much higher than SVR. Sometimes it's not the PVR. Like think about a patient who would have like very abnormal pulmonary vasculature, like blocked vessels by clot or diminished pulmonary vascular surface, and because of that, you're not able to fit the entire output. So there could be other reasons. It might not just be the actual resistance that are high in the sense that it's constricted. It could be also a fixed issue, like there's not enough vessels. So again, we see here in 2D, the duct, we can measure it at the pulmonary end, and you can see that it's completely right to left. And that's when you put the actual CW through it, you can see that it's right to left throughout the cardiac cycle, both in systole and in diastole. And it's pulsatile. So it allows this pulsatile flow, but in the other direction, in the right to left direction. Okay. This is another example of a right to left PDA here. We see it here in bidimensional clip, and we can see that it has this blue flow as we're sweeping towards the aorta. Strain by STE, I'm not sure we're going to go over this today. I did put the slides so that they're available. And there are some terminology that I made available about strain, as well as some of the normative value that have previously been described for some of the echo parameters we described today. I've put the kind of graph that we described the pressure. And I ended this presentation, so you have it available on the Neocardio Lab with some of the important kind of physiological concepts that you kind of need to know. So what's a stroke volume? What's an ejection fraction? How do you calculate a cardiac output? The FIC principle is actually what we use when we do a cath lab in order to kind of estimate cardiac output. It's not necessarily well adjusted to newborns, but it's still something that we use. What's a pulse pressure? what are the resistance and flow and how do you calculate them? So that reminds me a lot of nightmare from physics when I was in college, but it's kind of important to know these things, as well as what, the resistance being kind of a factor of the viscosity, the length, and the radius or diameter of the actual vessel that it's taking. You need to learn what are these pressure volume loops. Pressure volume loops are applicable to the RV and the LV. Here, this is just the LV, but you could pretty much replace pulmonary valve and tricuspid valve for the mitral and aortic valve, but they're obviously not going to be the same pressure. And you can see that this pressure represents mostly an adult, so you would have to like scale down for newborns. So this is what would happen in terms of your left ventricular volume relative to the left ventricular pressure. And you can see that, eventually the left ventricular pressure, they go very low during the diastolic phase of the cardiac cycle, and then they start rising as you get filling, and eventually, you get emptying, et cetera, et cetera. This graph is also very important. It puts in relationship what you see in the right atrial pressure versus what you see in the pressure of the system. So exactly like I mentioned, yes, you're around 3 to 5 millimeters of mercury, but there is still changes in your atrial pressure throughout the cardiac cycle. For example, there's the atrial contraction, there's a right ventricular contraction that will reflect inside of the right atrium. Then you get part of, the descent, which is like the atrial relaxation and downward displacement of the tricuspid valve. And then eventually you get, the increased RA pressure due to increased volume facing the tricuspid valve closure. And eventually you get your right atrial emptying. But you can see that these pressures fluctuations are very minimal, but they might not be minimal if you have some kind of disease like tricuspid regurgitation, Epstein anomaly, arrhythmias, or RV diastolic failure and things like that. Similarly, you need to know what are the different representation of your left or right ventricular pressure relative to what's happening in the great vessel. So you remember when we said that your diastolic pressure and your LV are supposed to be low. Why? Because it's in the filling phase. So the LV is relaxing and eventually it's like sucks blood from the left atrium. And the same thing for the RV, it sucks blood from the right atrium. So the pressure is very low during diastole. But eventually during the contraction, you eventually will get a pressure that's much higher than the diastolic pressure into the great vessel. And then you start ejecting. And then these pressure will match because you get obviously the connection between the RV and the PA, or the connection between the LV and the aorta, so they will equalize pressure. So it's important that you go through the physiology of the cardiac cycle and understand the pressure, the volumes, and what's happening in the atrium relative to the activation. So that's it for this presentation. That's kind of overview of the different echometrics that we could use, and so how we do some of these measurements. So we will open for question, but I'll close the recording.